Okay, so good morning. Good morning, everyone. Uh, Welcome to this webinar. I am Qutub Jamali. I'm a neuropsychiatrist, and this this webinar is, as we all know, it's about CESR, but it is mainly about my CESR journey. Uh, because I've recently got into the specialist registration via portfolio pathway, so I thought that I'll share my experience. Uh, so before I share my screen, I've done a presentation. So that presentation would be for half an hour or so. Because I'm doing this is my first live webinar on YouTube. Whilst I was preparing for this, I realized that we cannot have verbal chats. But then again, if you've got any questions, just feel free to put it on the chat box. When I will share my screen, I may not have access to the chat box at that time, but once I've completed my presentation, I will see the chat box, and then I'll answer as many questions as possible. So it's a 90-minute webinar. So the first half an hour would be presentation, and then you will have an hour to answer any questions. Yes, this will be available later to watch because it's a YouTube webinar. My understanding is that it automatically gets uploaded. Hence, I would really appreciate that when we are asking questions, please ensure that we are not putting any identifying details of patients or family or anything. We will focus purely on academic CESR competencies. So just be mindful of that. So without any further delays, I will now share my screen. So can I just quickly check, are you able to see my screen, the presentation? Okay, perfect. So, and see, right now I am on the CESR portfolio presentation. Can you see that? Perfect. Okay. So, but hold on, I think. Okay, sorry, I'm sorry because I'm new to this, but are you able to see the RC site page or the CESR presentation? Ah, yes. Okay. So I think I'll have to see how I can change this. Found it. Yeah, I'm sure you will be able to see the presentation page now. Fantastic. Fantastic. So I think what I need to do is, now that I've got CESR, I need to focus on improving my technical skills. Right. I'm a consultant neuropsychiatrist. I've got my specialist registration in old age psychiatry. And today we will cover my journey timeline, basically, why I chose CESR. When did I start working on CESR? How did I collect the evidence? What happened at my first and second submission and at review application? So why CESR? Just a quick background. I started my career as a GP. I worked as a GP for 3 years, and then I switched to neuropsychiatry. Whilst I was doing my GP, I had a special interest in psychiatry and chronic disease management, and I felt that I think psychiatry is better for me. But in order to make a smooth transition, I did neuropsychiatry. I worked as a registrar in 2014 for 4 years, where I did a lot of rehab work, neuro rehab and neuropsych. So that was a smooth transition for me. I worked as a neuropsychiatry registrar for 4 years, and then I felt that I think I made up my mind that I would like to now work as a consultant in neuropsychiatry. Um, but then I realized that neuropsychiatry is not a CCT specialty, so old age psychiatry was very close to that, and hence in 2018, I moved to the UK, and then I had my first job as a specialty doctor in old age psychiatry. Now, when we moved to a new country, and I moved to the UK with my family, uh, I again we always have this dilemma whether to go for a training or a non-training post. It was 1 year in the UK, and I had to make that decision. Because I had a GP background as well. Again, the confusion set in that, shall I go for GP training or shall I go for core psychiatry training? And I applied for that, obviously, and I was also shortlisted. But then I just felt that in training, you have rotations, you may have to move from one place to another. And because I came in with my family, so I needed that stability. Hence, I felt that because I've got this medical and psychiatry experience, and I was feeling confident working as a specialty doctor at that senior level, I felt that maybe a non-training route would be appropriate for me, and that will give stability as well to my family. Hence, I decided in 2019 that I will go for the CESR route. Now, in 2019, it was still CESR. The CESR moved to portfolio pathway in late 2023. Now, I've mentioned first appraisal here. The reason why I mentioned first appraisal is that that was my first appraisal in the UK, and in my PDP, I mentioned in my personal development plan that I am going to pursue CESR. Now, this is important as well that it is mentioned in your appraisal, because when you're going for a specialist registration via non-training route, you are not doing ARCP where your yearly progress is monitored. So for non-trainees, I think the appraisal is a good tool for that. Hence, it was mentioned in my first appraisal that I'm going to pursue CESR route. Now, I got this opportunity to take the CESR development post, which was a specialty doctor post in old age psychiatry, but it was a CESR development post. It was a fixed term post for 3 years, where the trust supported me with with the competencies and evidence required. So I will spend more time on this slide because I would like to share what exactly I did in those 3 years. Now, in 2019, I think August 2019, I started this post. And my first rotation was in the community in old age psychiatry. So I was doing CMHT, and I was also covering crisis team. I also did memory assessment clinics as well. So again, that gave me an opportunity to get evidence related to community setting. Now, I've mentioned CESR ARCP here. So I mentioned before that in training post, you have your ARCPs, but in CESR, you don't. But my trust was very supported, and they kind of uh, they designed the CESR development post in such a way that it kind of mimics the higher training rotations and competencies and assessments. So I had ARCPs. I had two ARCPs in 2020 and 2021, which showed the progress along with the appraisal. The reason why I felt this was useful as well, because I was also mindful of the eligibility criteria, that you need to have at least a specialist qualification in the specialty you're applying for, or you need to have 6 months of specialist training experience. Now that is what is mentioned in the on the GMC website. There is no mention of specialist training in an approved training program. So I was hoping that whatever I'm doing, this will help in meeting that eligibility criteria. And I was still under that assumption. However, it was still at the back of my mind that because this is a CESR development post, I don't have a training number. So I was still unsure whether this would be considered. But I still went ahead, and I was getting all the evidence required. So in the community, case histories, teaching competencies, research. So I have interest in research, and when I started my CESR evidence gathering, I was also suggested by my supervisor that there are two competencies which takes time. One is psychotherapy, and the other is research. Hence, I started doing the research, and even in 2019, 20, and 2020, I also joined the Ballon group. At that time, that was the starting point, which is the case even now. I also got an opportunity to work as a medical education fellow. So the trust where I was working in, they were appointing medical education fellows to, SAS doctors or higher trainees were eligible for that. So I applied for that, and I got that opportunity. So again, that was a good experience to have, where I was supporting resident doctors, core trainees, with their competencies, delivering teaching sessions, doing medical education related QI projects, and everything. Towards the end of the rotation, I was also provided with a supervisor report. So my clinical supervisor provided with a detailed report. I also got my ECT competencies, and I joined the rota. Now 2020 was I joined the rota right at the time where COVID happened. So again, there were some delays there, but nonetheless, I joined the rota, and I continued doing ECTs. Then in my second rotation, 2020, 2021, I was given an opportunity to work in an inpatient setting, old age psychiatry inpatient settings, where again I got an opportunity to collect case histories in an inpatient setting. I was able to get some teaching competencies. Now, when it comes to research, in 2020, I applied for ethics approval. I had a research proposal in mind, and then I applied for the ethics. Towards the end of 2020, I got ethics approval. So basically, I was the principal investigator for that research project, and the trust research and development team supported me with that. So usually when you are applying for ethics, you need to have the research proposal and sponsorship from your trust, which I was fortunate to get that support. So I got my ethics approval, but I couldn't start the study because of COVID. So that got a bit delayed. but nonetheless, I was able to show that I had an understanding of research methodology, writing a research proposal, doing literature search, literature review, because when you're doing the proposal, you're also doing a thorough literature review. So that is what is required. When you're doing a literature search, and then when you're reading these articles, are you able to critically appraise these articles? And that is what the whole purpose is of your research competencies. So I was able to do that, even though there was a delay in the start of research. I started psychotherapy. I was supervised by a senior clinical psychologist. I think she was band 8. So that is a criteria. Either it has to be a consultant medical psychotherapist or a senior clinical psychologist. I think band 7 and above. That is a criteria. So I was supervised. I did. I was able to do cognitive analytical therapy. Uh, it was I did 16 sessions of that. In that cognitive analytical therapy, I was able to do the sequential diagrammatic reformulation, write a reformulation letter, do sessions under supervision, write a goodbye letter, and was also able to do compassionate focus therapy as well along with that on one patient. So that was handy. I also did some family therapy sessions there. So like just on one patient, I was able to get many psychotherapy modalities, but primarily I was signed off for cognitive analytical therapy and compassionate focus therapy. Whilst I was doing my inpatient role, I also had another opportunity to do another psychotherapy modality, which was bereavement counseling. Now, so again, that was a short case. I did 6 sessions with the patient, and that was supervised. And for all my psychotherapy competencies, I received a testimonial from the psychologist. I got the SAP and the PACE done as well. Because then I think in psychotherapy is one of the competencies where secondary evidence is required. So I was able to do that. When you're doing inpatient, you have to provide evidence of clinical leadership. So I was able to do tribunal reports, managers hearing reports. Then I attended the hearing where I was presenting the case. So when you're dealing with medical legal work and when you're submitting evidence, you have to try and triangulate the evidence. So you've written a tribunal report where your name is mentioned along with the RC because you're not the RC at that point. Then you are presenting the case at the hearing where the RC is there supervising. You are asking also, just make sure that when you're doing these hearings, you request the minutes of these hearings as well from the Mental Health Act office, and they will readily provide you with that. So make sure that you take those minutes where your contribution would be mentioned everywhere in the minutes that Dr. Jamali mentioned this or that. So that is very valuable. That is a primary evidence to demonstrate your active role in that hearing. So you've got the tribunal report, you've got the minutes of the hearing, and then you are now triangulating the evidence either through reflection or you're doing, and as well, obviously, it's always good to be reflective at your work, but then along with the reflection, you can also get a workplace-based assessment done like DONGs. So that is how you do, you submit your evidence for one particular competency. Then you should also demonstrate competencies of chairing ward rounds, or CPAs or family meetings or discharge planning meetings. So you should be able to chair those ward rounds because or these meetings, because that is the whole purpose of being a consultant. So I had an opportunity to chair those meetings either in the presence of the consultant or the RC, or even when the consultant was on leave, I was given the opportunity to step up and chair these meetings. So even in the absence of the consultant, the work was as usual, where I was chairing all these meetings. Now, because at this point in time I didn't have my MRC Psych, uh, the criteria at that time was that it is still there. It is still there in the new curriculum that if you don't have MRC Psych, you need to. And so, say if I applied in old age psychiatry, if I needed if I didn't have MRC Psych at that time, and if I was submitting, then I need to submit some case histories in other specialties as well. So because I was in old age, so I submitted case histories of general adult and some case histories of CAMS. These are the core requirements. You don't necessarily need forensic or anything, but so say if you're doing so you're working on CESR in general adult and you don't have MRC Psych, then you need to submit case histories in some case histories in old age or some in CAMS. You don't have to submit lots of case histories. So like the special interest case histories could be, say, 3 cases in general adult, 2 cases in CAMS. So that is okay. So like in my second year of CESR development post, I did some special interest sessions in general adult, and I was able to provide 3 case histories then. I did an audit as well. So I did 2 audits there. One was I was the co-supervisor, and in the other audit I led the audit. So that was the first cycle, though. Again, you have to be mindful. You have to complete 2 cycles to complete the audit. Again, I was mindful that look, I still don't have MRC Psych. So whilst I was collecting all the evidence, I was simultaneously preparing for MRC Psych. Unfortunately, I started with paper B because of my research background. I thought I'll ace it. It's going to be a cakewalk for me, but unfortunately, it wasn't. So in 2021, I attempted paper B twice and I failed twice. Then in late 2021 and then 2022, my third rotation was in hospital liaison. So it was all ages, actually 18 and above. But then I collected old age case histories because, again, when you're submitting old age psychiatry cases, you have to submit cases with physical and mental health interface. And although you can easily get that done in community and inpatient, but in liaison, more often than not, you will see pure delirium cases. So I had that opportunity and I collected evidence with proper physical mental health interface, physical examination, and everything. So I was able to do that. Now, interestingly, when I was doing this liaison post, I didn't have an on-site consultant there. So basically, I was the only one over there. Although I was a specialty doctor, but I was working autonomously, just like a consultant. So that gave me an opportunity to chair many clinical governance meetings, whether it is about anything related to any service-related QI project or dealing with any incident, or even like any sort. So like I can give you an example. When I was working in hospital liaison, we had an issue where if we would prescribe an antipsychotic, then or if an antipsychotic was prescribed by a geriatrician, the community mental health team wouldn't take over the antipsychotic monitoring. And so then the liaison team got involved, and then we prepared a shared care agreement and the protocol of how to refer somebody who was prescribed an antipsychotic by a physician. The idea was for the liaison to have an oversight and then do the referral to the community teams for antipsychotic monitoring. So this was just one of the examples of getting the competencies around clinical governance. I started my research. I was the principal investigator. My other colleagues joined in as well, who helped me with data collection, analysis, and then we were able to complete this research project. And I completed the report, and then it got published as well. So along with being the principal investigator in a particular research project, so that it was a cross-sectional study. But along with it, since 2019, I had made up my mind that I'm having at least one publication a year. And I like doing review articles. So I was doing my review articles, and I was able to publish every year. Again, review articles are also a great way to demonstrate your research competencies, because you have a question in mind. You are able to find the answer of that clinical question through thorough literature search and then literature review, and then you are summarizing that evidence in the form of literature review. So I think it's an excellent way to demonstrate your critical appraisal skills here. I continued with my audit, and as I mentioned before, I did my special interest session in CAMS, and I was able to get 3 cases in CAMS. And then at that point in time, I did my appraiser training, and then in 2022, early 2022, I was appointed as an appraiser in my trust. So again, when it comes to teaching, I think we have to be very mindful that it is teach, assess, and appraise. So you need to show all these 3 competencies: teaching, assessing, and appraising. So when you're delivering teaching sessions, that's fine. But again, just a quick overview on that. When you're delivering teaching sessions, make sure that there is an evidence to that in the form of PowerPoint presentation, and then feedback from the students or trainees, and then maybe triangulated with reflection or a workplace-based assessment by your supervisor. But again, you're doing the teaching element, but then there is an assessment element as well, that you are assessing, you are doing workplace-based assessments for your trainees. So that is something which also needs to be submitted. And then you are appraising as well. When I was doing community work, I was able to do the supervisor report for a core training in the absence of the consultant. So I was fortunate enough to capitalize on that opportunity. Now, by 2022, I had all the evidence. And I was hoping that even though, again, it was still at the back of my mind, whether I still meet the eligibility criteria or not. Because I had evidence, I thought, let me give it a try. And then in 2022, I had my first submission. I submitted my application. Unfortunately, it got rejected in the first step, at the very first step, because they mentioned that I don't meet the eligibility criteria. And it was at that time they mentioned clearly that although I did submit my supervisory report and the CESR ARCP reports, the specialist training I had was not from an approved training program. And whilst they knew that I'm a qualified GP, and during my GP training, I had psychiatry placement, but that was not accepted as well. So at that time, I had no other choice but to pursue MRC Psych in order to meet the eligibility criteria. Now, I don't know, for some strange reason, I started with paper A, although I attempted paper B twice before. But I don't know. I think the first, when I reflect on this journey, I think the first mistake was I should have taken. I always knew at the back of my mind that my eligibility criteria is still a bit dodgy. I should have focused more on MRC Psych, maybe way back in 2019 or 2020. Which I didn't, unfortunately. Although I did, I kept attempting, but maybe the focus was not there. But now in 2022, mid 2022, I realized that I've got no other choice but to go for this. I started with paper A and I failed. But then I attempted paper B later that year and I passed. So again, at least I made a start. I at least passed the first paper. And again, although it was a disappointing start for me, at least I was, but I kept myself motivated, and I was doing a lot of other things simultaneously to ensure that I'm maintaining my competencies. And because I was heavily involved in teaching, and I also became an appraiser and all, I was finally I submitted an application to become an accredited or recognized clinical supervisor. That was then accepted by the trust, and then I got on to I was recognized by the GMC as well as a clinical supervisor. So that was a positive. And then whilst although I had the case histories, but I continued finding those unique case histories, so that just in case when I'm ready, I've got a good collection and I can pick and choose from there. And I continued with my research and publication work, and I continued with my appraiser work. 2023, I feel professionally it was my big worst is a wrong choice of word, but I don't think there is any other word which is coming to my mind, but that was kind of the biggest disappointing year for me. I received a specialist contract, which was good news. So from specialty doctor, I moved to a specialist. Previously, it was called associate specialist. But unfortunately, I attempted paper A twice. I failed twice. Now, I had an opportunity to go for paper A again, because in 2023, they added another paper A exam slot. I think I attempted one in April, and then I failed that, and there was another opportunity in July. But because I was due for ILR, and we know how expensive ILR is, I had no money to pay for another paper A exam. So I prioritized indefinite leave to remain application, and I got my ILR. Because there were delays in CESR, I felt that I think I should now focus on the approved clinician status. I started working on it in 2023 because in my specialist contract role was 2 days, 2.5 days in CMHT and 2 days in inpatient. So then I was able to get my AC competencies. But when I submitted my AC portfolio, I received an extensive feedback on the initial scrutiny, which was very extensive. So, and I felt a bit overwhelmed that how will I get all these things done? But I got it eventually. So now in 2023, I think October, November, there was a change in curriculum where the KSE cohort system came in. Now, at that time, I checked the cohort system 1A, 1B, and 2. And I felt that although I don't know where I was going with MRC Psych, I just felt that could I be eligible for cohort 2 then? Then I contacted the I contacted the GMC, and they advised that even though there is a cohort 2, I still need to meet the eligibility criteria of either a specialist psychiatrist qualification or minimum of 6 months of training in the area of specialty you're applying from, but from an approved training program. So I was again stuck again, and I was disappointed again. But I continued, I persevered, and I was collecting case histories and other evidence because I became a clinical supervisor. So I had to then, during my appraisal, I also had to maintain the clinical supervisor status. So I had to submit evidence related to that. So, and then I also submitted evidence related to my appraiser role as well, because I started working as an appraiser then in 2022, 2023. So again, I was collecting the evidence simultaneously. 2024, I think, is the one of the best years of my professional career. I resubmitted my AC portfolio. I passed my paper A eventually in my 4th attempt in May 2024. In May 2024, I got my AC status. In October 2024, I attempted CASC, and I passed CASC in the first attempt, which was kind of a miracle for me because it took me 4 attempts to pass paper A, 3 attempts to pass paper B, but I passed CASC in the first attempt, which was handy. It saved a lot of my time. Then I was ready. I was because now I meet the eligibility criteria and I had all my evidence ready. So then I was very confident that now I'm ready to submit. But then the question was that now that I have MRC Psych, would it still be cohort 2? Now, at that time, it was not very clear as it is now. At that time, the criteria was the first question with regards to cohort selection was, do I have core psychiatry training? I didn't have that because I came from a GP background. So did I have core psychiatry training? And that has to be a structured training for 3 years. You have to submit the curriculum if it was done out of the UK. I had no evidence. Now, that was the first question. If you had core training, then the second question was that whether I had MRC Psych. But because even though I had MRC Psych, I didn't meet the criteria for core training. So if I met the eligibility criteria, but I didn't have core training. So if I didn't have core training, then the straightforward answer was that I'm eligible to apply under cohort 2. Now things have changed. If you have MRC Psych, that is equivalent to core training now. So say if I would have submitted now, I could have submitted under 1A. But again, it is what it is. So at that time, I submitted my application under cohort 2. I was aware of the prolonged and the long processing time, but then because I've been active in research, I applied for MD research, and yes, fortunately, I received an offer letter to pursue MD research, which I started in 2025. So I was in my first year, and I also got an opportunity to work as an associate medical director for older adult services. Again, that was a big boost. It helped me to submit competencies with regards to management and leadership. So that was a big positive. My CESR application in the first 6 to 8 months was under process. It was a long wait. But when, as you know, the process that initially it goes to the GMC specialist advisor and then it goes to Royal College. So before it goes to the Royal College, you still have opportunity to submit more evidence. And at that time, I took that opportunity to submit evidence related to my AMD role. So again, that was a big boost that helped with my management related competencies. And then, unfortunately, in September 2025, my application got rejected, but I only had one recommendation. That recommendation was to submit 5 old age case histories with detailed physical health examination, with the proper follow-up plans. And I was advised to submit 2 case histories in CAMS or learning disability. So that was the feedback I got. I started working on it. In 2 months, I was able to collect all that. And then I resubmitted in November 2025. 2026, I was in my second year. Whilst my review application was under process, I was offered a consultant neuropsychiatrist job, which was a big positive for me. And then my review application was successful. I was on the specialist register in old age psychiatry. If I reflect back on my 6-year journey, I feel that I've achieved a lot despite the hurdles I faced. I made mistakes, agreed. But if I reflect on it, since 2019, I was doing my clinical work as a specialty doctor autonomously. Hence, I was offered the specialist role. And since 2019, I was doing my clinical work autonomously. I was able to have my career progression from specialty doctor to specialist and then AC. I had my publications. I was the principal investigator, started my MD research, appointed as an AMD, active in teaching. I also did a research supervisor role for University of Liverpool for a year. So again, I included that in my CESR evidence. I worked voluntarily as a research supervisor for a year. I think it was in 2022, I think it was. And then I worked as an appraiser. I continued working as an appraiser. And then towards the end of my CESR, where I was very at an advanced stage of submission, the trust offered me the role of CESR coach or mentor, which I accepted. And I used that in my CESR evidence. I got MRC Psych, which was a big boost, a big achievement for me. And then whilst I was doing all this, I was able to secure diploma in neuropsychiatry and child and adolescent psychology. Again, that was I think that was an achievement for me as well, whilst doing all this work. And then obviously I eventually got the specialist registration via portfolio pathway. This is my last slide, I promise. The takeaway is no plan is perfect. The focus is important. There will be hurdles, but don't worry about it. Don't assume anything. That is what the mistake was. I assumed that I would meet the eligibility criteria, but don't assume. Follow the SSG guidance, specialty specific guidance, and follow that and prioritize what is required at that stage of your CESR journey. You ask your colleagues, you ask your seniors, but double check with GMC and Royal College. Very, very important. Keep trying. Don't give up. Don't lose hope. Don't feel discouraged. Just keep trying. Success will come, but you have to persevere. It is a self-directed learning. One of my senior colleagues, they tell me that they told me once that when you're doing a training post, you are on the lift and then you will reach your destination. But when you're doing CESR, you're using stairs. So it is self-directed learning. You have to, even though I was on a CESR development post, I had to still look for my competencies and reach out to people, because most of the supervisors we have, most of them would have come through CCT route. So they may not have enough experience of CESR and the competencies and the creative ways where we can collect evidence. So again, it is all self-directed learning. Keep yourself busy, distracted, keep learning. So even though there was a delay in my CESR, I did a lot of things which I've already mentioned. Keep the confidence going, because when you get your CESR, you're so prepared that you are a confident consultant from day one because of the work you've done. So keep that confidence going. Yes, there has been issues around CCT being more recognized worldwide than CESR. Agreed. That is a harsh reality. However, if you've got CESR, you have MRC Psych, and if you're active in research and management, your profile is very strong. So it will be recognized. I will just give you an example. Whilst I was waiting for my CESR, I randomly contacted one of the doctors who is involved in recruitment in one of the Gulf countries. And I told him about my qualifications. And then he said to me that, look, you've done MRC Psych. MRC Psych is only about passing exams. And then I felt, okay, well, do you think it's that easy, passing the MRC Psych exam? So even though people have passed in the first attempt, but again, it is still not easy. So if you don't feel valued, just don't apply. Apply where you feel valued, respected, and your work is respected. So always think about it as well when you're applying for it. Feel very confident and proud that you've achieved this. You've achieved CESR. It's no mean feat. It is a massive achievement. I will stop sharing now. And I'm up for questions. So my cohort was 2, but that was in 2024 where there was limited clarity. Now, if I would have applied now, considering I have MRC Psych and specialist experience, maybe it was a cohort 1A for me now. So there is there is an email address on GMC. I think it's portfolio at specialist registration, something like that. Just check the GMC website. You can contact them. They will get back to you in 5 working days. Good question. So again, well, initially when I received that feedback, even I was wondering why. But then when I was working on my special interest cases in general adult and CAMS, I was advised that it doesn't necessarily have to be of a specialist level. You can do it as a core competency level. So on reflection, I feel that maybe those CAMS cases were not very detailed. I felt that it was at a core competency level, so I will include the positive findings and do a usual core level case history. It was not very extensive as the old age cases. So I think maybe that was the reason why they asked me to submit 2 more cases in CAMS. No, because that was the alternative. So if you don't do co-training, you have to submit these special interest cases. But I feel it was not of a consultant level or higher training quality. I received, and this was my advice, that this is the advice I received, that your special interest cases in general adult and CAMS can be of core level. But I guess that was not the case. Any more questions? So I've done videos on eligibility, CV, case histories, and cohort. So have a look at it to get more information on which cohort you may fall under. How much older adult evidence can we provide? Again, it depends on your cohort. So if it is cohort 1A, then you have to submit 10 case histories. If that is what you're referring to, oh, sorry, I get it. How much older evidence can we provide? So when I was working initially on CESR, it was 5 years, last 5 working years. Now it has changed since late 2023. You can submit evidence of the last 10 working years, right? So you have to be, it doesn't matter whether it is full-time, part-time, but it has to be last 10 working years. Now there is no specific reflection style. It is your way of expression. So you can you don't have to use any specific format. What I tend to do is I do it on a Word document where I mention about the background, what I did at that time, what was the good thing I did, and what were the areas where I could have done better, and what was the takeaway from that experience. So that was my reflection. One thing which I can advise, you don't have to do it actually. When I was doing my AC competencies, that really improved my reflective skills. So if you've done AC portfolio work, you can still submit some of your AC portfolio work for CESR eventually. The reflective case commentaries you do in AC, that is so extensive. So when you're submitting your evidence, you have to, if you look at HLO1, you have to submit evidence of your reflective practice. So you can submit that in your CESR. So I have some publications from a few back, and yeah, if it was in the last 10 years, you can use it, not a problem. Triangulation is okay. Let me give you an example. So say you've done uh, okay, let's take an example of a case history. You've done case history, you've completed a detailed case history, and now you're discussing that with your supervisor. The supervisor will hopefully do a case-based discussion, workplace-based assessment for you. So you've got your case history, you've got your workplace-based assessment, and then now you're doing a reflection on this. So that is how you triangulate the evidence. The other example is you've done reflection. So you've done a study or you've published something, say around 8 years ago. Okay, you've done that 8 years ago, but now you're reflecting on it. Maybe what you did 8 years ago is kind of relevant now. Maybe it is related to a case. So you're doing that reflection on that case, or on that publication. So you've done that publication and you're doing the case, you've done a reflection on it. And then maybe you can present that in your peer group. That when you're doing we all are in peer group, and there is a role of peer group in CESR as well, that in the peer group meetings, you do minutes as well of that. So say you're also discussing cases. So when you discuss a case, maybe you're bringing your research work done there, and then you're getting feedback from that case discussion from your peers. So case reflection, research publication, and feedback from your peers. So that is how you triangulate your evidence. Does that make sense? When you're working on CESR, it is always important to have a CESR mindset or portfolio mindset now. Sometimes you because we are very busy with our clinical work, but like if we know that this that we are working towards CESR, how can you make the most of the work you've done and use it for your CESR evidence? So say for example you are working in CMHT, you are attending complex case meetings there in CMHT. uh, you are chairing that meeting, and you are discussing this complex case, and the minute would be there. So you use those minutes to demonstrate your clinical leadership skill. So the minutes would be done by the admin. You're using that minutes to submit that evidence that you've demonstrated your clinical leadership skill there. So it's about being CESR minded. uh, yes, a good question. So when it comes, if you are doing community old age, in order to provide evidence for management, you don't necessarily have to be in a managerial role for that. No, you can do by doing some QI, for example. If so, say you have identified a service-related issue or gap, for example. Now, just to give you a random example, you've in your service, in your community team, uh, there is no ECG, for example. Okay, now, or you've got ECG, but there is not enough training for ECG, where you can interpret ECG and provide some advice. So maybe that there is a gap there. So you can do a QI. You lead this QI and try to identify the gap. Use a PDSA cycle, plan, do, study, act cycle. See how you can manage this. How can you resolve this issue? You've been able to resolve the issue. Now you're repeating the PDSA cycle, that whether whatever changes you've made is now working or not. So again, doing a QI is a great way to demonstrate your management skills. It will be more service related, right? The other thing is being part of the interview panel. right? So you are interviewing maybe a trust grade doctor, resident doctor. Ask your HR whether you can be in the interview panel. So that again, you are addressing some service related, issue. There is a gap, and you are part of the recruitment process. So that is another way to demonstrate your management skills. Um Incident reviews, that is, you can identify, you can get into that very easily. Contact your team in your trust or hospital. They would be able to provide you with some incident review reports. So that is another way. uh, but triangulation can also include evidence of the case. For example, a letter to the GP, that is your primary evidence. Yes, a letter to the GP, that is your case history, right? Um you can triangulate that evidence by adding a reflection to that case history and doing a CBD with your supervisor. So that is how you triangulate. Or the other way of triangulating this is, now you've done an inpatient case. Okay, you are doing an inpatient case. You're submitting the case histories, a detailed case history of initial assessment, then follow-ups whilst the patient is there. You are attaching the minutes of the ward rounds you chaired, or the CPA, care planned approach meetings you chaired, or care programmed approach meetings you chaired. You add the minutes with the case histories. You add the discharge planning meeting minutes in the case history. So you've got a case history from an inpatient setting. Along with it, you're adding minutes of the meetings you chaired, and then you're reflecting on it. So you can triangulate. Now, again, the other thing is, you don't have to triangulate every evidence. You don't necessarily have to do that. Otherwise, it's, you're adding huge numbers of pages there, which the evaluator may not like. Obviously, like, may not like is a wrong choice of word, but maybe you're duplicating work there. So make sure that you're focusing on the quality. You triangulate the evidence where you really have to triangulate. In case histories, maybe you may not have to. So again, it's about choosing which competency or evidence you want to triangulate. Which HLO would interview panel go under? So management leadership, management and leadership, it could go under that. Uh, no, you you don't have to do CBDs for all cases. But interestingly, one of my seniors at that time, they had to submit 30 case histories. There was no cohort system. In the old curriculum, it was clear 30 for everyone. So when they were doing 30 case, so I know that doctor submitted workplace based assessment for every case histories. You don't necessarily have to do that. And again, CBD is not mandatory. That is secondary evidence. It is not mandatory. Primary evidence, your case is, you will be evaluated based on your case history, not CBD. So you don't have to submit 20 CBDs for that. And but yeah, for psychotherapy, yes, you need SAP or PACE or supervisory report or testimonial. That is required. So let me see if I've missed any questions. So now in cohort base, it's 1A, 1B, and 2. So if you are under cohort 2, then you have to submit 30 case histories. If it is 1A, it is 10, and then if it is 1B, it is 20. And again, it's not specific that you can only submit 10 case histories. Sometimes you may have to submit more to demonstrate your competencies in different settings. So just make sure that even if you are eligible to submit 10 case histories, nothing is stopping you to submit 15 case histories. So don't worry about that. The other thing to be mindful of is, if you're working in community, you need cases from other settings as well. So say if you're working in community as well, you need cases from different settings, from CMHT, from crisis team or rapid intervention, whatever it's called in your area. You need, if it is old age, you also need cases from memory clinic, memory assessment service. It is mandatory. So even in community, you need cases from different settings. You also then have to have cases from inpatient. So very important. So say if you're submitting 20 cases, it has to be divided accordingly. Some cases from CMHT, from crisis team, from memory assessment, and some from inpatient. If you can, some from hospital liaison. So you have to submit cases from different settings. I'm just thinking now of management related competencies. Yeah, so I've got some questions here. Yes. So as one work in old age, how do we get cases from CAMS? Uh, so when it's a non-training, we work in non-training post, but in every post, you get your SPA time, isn't it? Supported program activity. I think that's what it stands for. You have to use your SPA time. Maybe so. Say if you're working in community, maybe you have to use your SPA time doing some cases in inpatient. But that is something you have to figure out, and your line manager will have to support you with that. If it is CAMS, for example, or so say if you're working in old age, you're working on CESR for old age, and if you want cases in CAMS or general adult, you have to use your SPA time or your annual leave or your study leave by doing some cases with them. So what I did is that I liaised with the consultants from other specialties that look, I'm working on CESR and I need 2 to 3 cases in CAMS. Would it be possible that if I can do some sessions and I can take some cases, I can review, I can write a case history, and if the consultant can have a look, most of the time they will agree. If they don't have the capacity, they can signpost you to other consultant who would be able to support. That's how I collected my case histories. But yeah, the only way is utilizing your SPA time or annual leave or study leave for this. I use my SPA time, and I didn't use my annual leave. Annual leave for me, annual leave was, I was chilling at that time, because you also need some time to relax. But yeah, I took some study leave for this, because again, this is part of your study, isn't it? So you can use study leave for that. How do I send cases from previous trust? So yes, so now that is, so it becomes a bit tricky if you have moved trust and now you don't have access to the records there. It becomes very tricky. So ideally, when you are working in the trust, it's better to get all the evidence whilst you're working in the trust, so that even if you move to another trust, you've got the evidence ready. So, and If you have collected evidence from another trust, you need to have a verifier from that trust to verify your evidence. Again, verification of documents is essential, otherwise your evidence will not be accepted. The only evidence which doesn't need verification is your reflections, your appraisal documents, and your CPDs. That for that verification is not required. But case histories, any teaching competencies, appraisal document, work as an appraiser evidence, or supervisor evidence, or management evidence, all that has to be verified. So, say if you want to collect evidence from your previous trust, whether you've collected or you're in a position to get those from your previous trust, it has to be verified by the consultant from that trust. I hope that makes sense. So whilst we are waiting for more questions, oh yeah, there is one. Yes, taking evidence from other trust, obviously it has to be anonymized. So very important. And that is where the ideal scenario is, that whilst you are working in the trust, make sure that you're taking all the evidence and you're anonymizing it. So even if you're verifying, you're sending the documents for verification, make sure that at that time it is already anonymized. Everything has to be anonymized. There could be a time where I've also seen other doctors where they collected evidence from one trust, but then they collected evidence from another trust at the same time, maybe doing some special interest sessions in other specialties in another trust. But again, it's about ensuring that you're following all the confidentiality aspects, and anonymizing everything. So that is very important. But just make sure that it can only be verified from the consultant working in that trust. So, see, for CESR, you don't need AC. So once you have your CESR, you automatically you are eligible to apply for approved clinician status. So if the focus is pure CESR, you don't need AC. But whether AC is helpful, yes, it is very helpful. You can use your AC evidence even for CESR. So when you're doing your AC, you are submitting tribunal reports, and that will be anonymized, of course. You can use that tribunal report for your CESR as well. You reflect on it, and then you can submit that. Make sure that it is anonymized. It will be handy because when you're working on AC, you will be doing some inpatient work. And whilst you're doing AC, you're chairing all these meetings, you're doing a thorough risk assessment, you are dealing with some safeguarding concerns as well. And that is also one of the criteria, HLO criteria, that you have to submit evidence where you have addressed some safeguarding concerns. So these things are also required in AC. So it will be helpful. But again, if there are time constraints and if you only want to focus on one aspect, then, and if your ultimate goal is CESR, go for CESR. Once you have your CESR, then AC is automatic. The other option is that when you work on the CESR for now, work on it, and then when you're submitting, the processing time, it takes long. Maybe that is an opportunity for you to get some AC competencies. The reason why I'm saying that is, again, you don't have to do this, but maybe there may be a possibility where your application will not be accepted in the first attempt. You may receive some feedback, and then you have to work on it and then resubmit as a review application. So you have to be mindful of the processing time. When you submit your CESR, your portfolio for the first time, the processing time is 9 to 12 months easily. It's a long time. And then if you're getting a feedback and you're submitting the review application, the processing time for review application is also minimum 6 months. So it is a time consuming process. Maybe when you have that time, maybe you can, once you've submitted your CESR, you can utilize that time either for AC. Sometimes, people tend to utilize that time where they feel that, they've submitted that application, but maybe they feel that maybe this is something I may get a feedback on. So they start working on it straight away whilst they're waiting for their application to be processed. So that is what I did. When I submitted my application in late 2024, I still felt that maybe I'm lacking in evidence in management. But fortunately, I was appointed as an associate medical director, so I was able to submit evidence related to management whilst my application was under process. So before my application went to Royal College, uh, I submitted my evidence in my for my AMD for my management experience before it went to the Royal College. So when it comes to management experience, doing minutes, I think when you're doing any management roles, um, taking using the minutes of those meetings is very important. Anonymize it, of course. Anonymize, redact everything, very very important. So anonymize it and then submit. You can do a reflection on it. So when I submitted my management experience role, I did a thorough reflection on it about my journey as an AMD. Although when I submitted my evidence, I was only 3 months into that. But then when I received the feedback, they actually included and accepted that as an evidence that about my experience in the first 3 months of the issues, the service related issues you face, the interpersonal challenges you face, um, the recruitment challenges you face, and all that. You reflect on it, and then you can demonstrate that what was your contribution in potentially improving those challenges. Uh, so that is how you get your management competencies. But for this, you don't necessarily have to have a management role. The moment you identify any service related gap, uh, you can use that as your management experience. Again, I've also seen doctors being appointed as the locality clinical lead. So that is also a management related experience. So, staff, colleagues, it's okay, but um, all patient identifier details, name, uh, then names of family, relatives, address. Even if they are in a care home, you have to anonymize the address of the care home. Even anonymize the GP surgery name, because that is also a potential identifier. Even anonymize the full date of birth. That is also an identifier, full date. So what I did is that I redacted the whole date of birth except the year, the final year, whether it was 65, 70, 75. I just left that, but before that I redacted everything, so that any potential identifier has to be redacted. You can keep the names of colleagues. Eh, to be on the safer side, for the first few cases, I even anonymized that. But then I was advised by my supervisor, you just can't anonymize everything. Otherwise, how would the evaluator know who that person is? Even if you want to anonymize colleague names, for example, you have to put in bracket what was the colleague's role, whether it was a community psychiatric nurse, care coordinator, or a GP, or any other specialist you liaised with. So that is something you can put it even if you want to anonymize it. But basically, you only anonymize patient identifier details. You can remove the GP surgery address. That is another patient identifier. Anything else? uh, any suggestions on any videos you want me to do? Any for regarding any specific uh, CESR portfolio competency or HLOs? Any specific competency you want me to cover in my future videos? Any particular HLOs? If there is anything which comes to your mind later, just put it on the comment box in any of my YouTube videos. I will then try my best to do a video on that. Any final questions? Okay, yes. Research. It can be daunting initially. And that, when I started my CESR, that is what I was advised, that research takes time. But usually, so like, you don't necessarily have to have publications. One thing we have to be clear. So what they are trying, what they are expecting from us is that, do you have ability to critically appraise articles? That's it. Why is it important? Because in our daily clinical practice we do face challenging cases, and we always revert back to books or literature, reading up on things. So it is about say you found a case where you felt that, look, this is not fitting into the typical diagnostic criteria. Maybe let me read up on this. So you've read up on this, you've done some literature search, you've read many articles, you were able to critically review those articles, and now you're summarizing it. So you've summarized it, and then you say you've done a 3,000 4,000 word review article, you've done a draft, and you have published, you have submitted for publication. So submitting for publication is enough in a way that to demonstrate that you've done a thorough critical appraisal of articles which you have included in your review article, right? So one is, publication is not essential. Again, even if you don't submit that work, again, that is okay, that is fine. The other way, which is mentioned in the SSG, is that, say you found a clinical related question, you have done a thorough literature search on that. If you are able to do a presentation on that particular topic where you're critically evaluating every articles, so either you can do that presentation in your peer group or in your local academic program, and you've done a research, you've done the literature search, you've done the critical appraisal, you're summarizing it in a PowerPoint presentation which demonstrates your critical appraisal skills. That is enough. You're sharing it with your colleagues, they are providing you with the feedback. And so how are you going to submit that as your research evidence? So you had a clinical question, you do a reflection on that I had this clinical question, and now I've started doing literature search. So when you're doing literature search, you are using PubMed or anything, right? So you're doing that search, you are generating a document that this was your the list of articles which you found based on your literature search. Submit that. Out of those, how many you shortlisted, include that. And then out of those, so usually when you're doing a literature search, firstly you're long listing the articles, then you're reading the abstracts. Based on the abstracts, you're shortlisting the article. Now you're reading the full text of the articles. Out of those full text articles, how many you've included eventually in your interpretation to find the answer to that clinical question, and how you interpreted that. So you can use that, in your PowerPoint, as a critical appraisal model, that you've done the search, you have shortlisted the full text articles. These articles were being, and then when you're doing the literature search, there is also inclusion and exclusion criteria. So you are including. So when you're doing that search, all these research database, they generate that search. So you can use that as an evidence. You critically appraise that, do a PowerPoint, present it, get a feedback. So look, in just that piece of work, what all you've included. You've included your literature search document. You've done a PowerPoint where you're demonstrating your critical appraisal skills. You've done a presentation where you're demonstrating the presentation skills. You're getting a feedback on that, and then you've done a reflection. 5 piece of evidence, where you can include that. You can include this in your research. You can include this in your teaching as well. So that is how you use your evidence to tick all these boxes. How do you deal with psychological frustration, disappointments, setbacks that comes while preparing the application? On that day, you feel very disheartened, sad, upset. Very common. Uh, yes, there was a time, especially in 2023, where I felt that apart from section 12, I've got nothing. That was the feeling I got. But then it is about taking a break, relax, recharge, and then restart. That is how I have dealt with things. So again, it's about keeping yourself busy, even if there are disappointments on that particular day. Just take a step back, relax, recharge, and then restart. That is how I've dealt with. And look, disappointments will come, even though, like, I've got CESR. Again, the struggle never ends. It's an ongoing thing. It's about how you deal with it. And then this is what I do. I just recharge and restart. Very good question. So far, what I've gathered is, I think the only option is PDF and Word document. So far, I don't know whether things have changed, but what you can potentially do is, you can put the if it's a video presentation, I assume that would there be a link to that? So maybe you can put that link on the CV, and so the evaluators or the specialist advisor can just click on it. So I did that, because because I've been doing publications, and I had an opportunity to do podcast with the publishers. So obviously I didn't put the video podcast, I didn't upload that, but I did put a link on my CV. So that is something you can do. So I also put a link of my YouTube channel on the CV when I was submitting my review application. So that is fine. But I don't think you can upload the video. But again, the other thing is, if you're submitting video evidence, sometimes, if you are supervising students, right, or trainees, so again, the student trainee details also has to be anonymized. So be mindful of GDPR, be mindful of confidentiality. When they are pressing that link, would they be able to identify these students again? So then that is breaching confidentiality. So just be mindful of that. So I put a link, where I had put a link on my CV where it was a podcast with the journal editor. So that is okay. or I did a podcast for my trust library. So they did a podcast with my co-author. So that is okay. Uh, but when it is a teaching video or something, and if there are images or pictures of your trainees or students, better to avoid that. So one final minute. Any final questions? But yes, I will do a video on research and other other HLOs as well. So thank you very much everyone for attending. I hope this was useful. Uh, I think when I will end the stream, hopefully this will be uploaded. Let's see how it goes. Next time, what I will do is I didn't realize that in YouTube webinar you don't have that face-to-face interaction. But in my future webinars, I'll make it more interactive. Maybe I'll do it through Zoom. So, but thanks very much for listening, and enjoy the rest of the day. And I'll see you again in my future YouTube videos and future webinars. Thank you very much. Take care. Bye bye.